Ankle block technique. 1 Overview. Regional anesthesia is increasing in its utility in the treatment of injuries, foreign body removal, and even in the operative setting. By providing a regional block, the affected anatomy can be properly cleaned, explored, and treated without causing unnecessary pain to the patient. In many settings, regional anesthetic is also preferred because it prevents the distortion of the anatomy commonly seen in local anesthesia. Regional anesthesia of the ankle presents a challenge to the provider because of the complicated nerve supply to the foot and the varied locations of the nerves around the ankle. However, by adequately anesthetizing the foot, patients can be offered relief from often painful injuries while the complex anatomy of the foot is examined and repaired. Providing local anesthesia to the foot, particularly to the sole, presents many difficulties. First, the thick but sensitive skin must be penetrated with a needle, which often must be a larger gauge than might be used elsewhere to pass through the skin. This can be very painful. Second, the underlying soft tissue of the sole is tightly bound to the fascia and does not separate easily. Injecting even small amounts of anesthesia locally into the sole can result in compression of blood vessels and vascular damage to the tissue that is already injured. But, with regional anesthesia, each of these difficulties can be avoided by blocking the pain sensation carried from the foot at the point where the nerves pass through a safe, readily accessible region of anatomy. An image depicting a cross-section of the ankle can be seen below. 2 Anatomy. 5 main nerves originate from the major nerve roots of the lower extremity innervating the foot, see the image below. The dorsal aspect of the foot is innervated by 3 nerves that run on the anterior side of the lower leg and ankle, 1 the superficial peroneal, 2 deep peroneal, 3 saphenous nerves. The volar aspect of the foot is innervated by 1 the posterior tibial, 2 sural nerves on the posterolateral aspect of the ankle. Complete regional anesthesia of the foot requires blocking each of the 5 nerves. 3 Medications. The most commonly used short-acting subcutaneous anesthetic agent is lidocaine, which can be given as 1% or 2% mixtures. Epinephrine 1:1000 may be added to both 1% and 2% solutions. Epinephrine is typically added to local anesthetic to cause vasoconstriction, prolonging the activity of the anesthetic and limiting bleeding. The time between injection and onset of anesthesia with lidocaine is approximately 60 to 90 seconds, and the effects of lidocaine typically last 20 to 30 minutes, up to 2 hours if mixed with epinephrine. The maximum dose of lidocaine in adults is 300 mg, 3-4 mg/kg in children. When mixed with epinephrine, the maximum dose is 500 mg, 7 mg per kilogram. Bupivacaine 0.25% or 0.5%, Marcaine, Sensorcaine, is a common long-acting anesthetic agent. The time of onset of these long-acting agents is approximately 10 to 20 minutes, but the anesthetic effects last 4 to 6 hours alone, and up to 8 hours when mixed with epinephrine. The maximum dose of bupivacaine is 175 mg, 2 mg per kilogram in an adult, but this is increased to 225 mg, 3 mg per kilogram when mixed with epinephrine. 50/50ths or 25/75ths mixtures of lidocaine and bupivacaine may provide the most optimal anesthetic for certain ankle anesthesia, providing nearly immediate relief from pain from the short-acting component, and providing up to 8 hours of anesthesia from the long-acting medication. Because regional anesthesia is administered some distance away from the wound site, and also because epinephrine should be used with great caution in distal extremities, anesthetic medications mixed with vasoconstrictors such as epinephrine are not recommended in ankle anesthesia. Table 1. Maximum dosing for the most common short-acting and long-acting local anesthetic agents. Medication. Adult. Pediatrics. Lidocaine. 300 mg, 3-4 mg/kg. Lidocaine with epinephrine. 500 mg, 7 mg per kilogram. Bupivacaine. 175 mg 2 mg per kilogram. Bupivacaine with epinephrine. 225 mg 3 mg per kilogram. Asterisk supplies. All injections should be performed under sterile conditions, with the area of injection cleaned with iodine or chlorhexidine. The size of the syringe varies depending on the amount of anesthetic given. Keep in mind maximum doses, but all injections should be given with the smallest needle possible in an effort to cause the least pain. A 25-gauge needle is small enough to provide little trauma to the skin and is an excellent choice for administration of anesthesia. 4. Deep peroneal nerve block. Anatomy. The deep peroneal nerve lies in the groove between the extensor hallucis longus and the tibialis anterior tendon. The hallucis longus can be located by having the patient flex and extend the big toe. The tibialis anterior can be located by having the patient dorsiflex the foot and invert the ankle. The injection site should be at the level of the superior malleolus and between the two tendons. Distribution of anesthesia. The deep peroneal nerve provides sensation to the web space between the first and second toe and a small area just proximal to the first and second toe on the plantar aspect of the foot. Technique. The surgical field should be prepared across the anterior surface of the ankle between the superior aspect of the medial and lateral malleoli. Raise a wheel of anesthesia in the subcutaneous space and direct the needle between the tendons of the hallucis longus and the tibialis anterior at the level of the superior malleoli. Insert the needle until it is deep to the tendons or bone is struck. Inject approximately 5 ml of anesthetic. Withdraw the needle and redirect 30 degrees laterally and then 30 degrees medially and provide an additional 3 to 5 ml of anesthetic. If anesthesia in the saphenous distribution is also desired, bring the needle back to the level of the subcutaneous tissue and redirect it medially towards the medial malleolus. Inject an additional 5 ml in the subcutaneous space. This will block the saphenous nerve. Pitfalls. Avoid inadvertent saphenous vein puncture. Intraneural injection will cause significant pain, therefore withdraw the needle a few millimeters and continue injecting anesthetic. 5. Posterior
lies in the groove between the extensor hallucis longus and the tibialis anterior tendon. The extensor hallucis longus can be located by having the patient flex and extend the big toe. The tibialis anterior tendon can be located by having the patient dorsiflex the foot and invert at the ankle. The injection site should be at the level of the superior malleoli. Here, the superior border of the medial and lateral malleoli are outlined in black. The tibialis anterior and the extensor hallucis longus are outlined in blue. The approximate position of the deep peroneal nerve is outlined in red. Direct the needle between the tendons of the extensor hallucis longus and the tibialis anterior at the level of the superior malleoli. Insert the needle until it is deep to the tendon or bone is struck. If bone is struck, withdraw the needle a few millimeters. Inject approximately 5 milliliters of anesthetic. Withdraw the needle and redirect 30 degrees laterally and then medially and provide an additional 3 to 5 milliliters of anesthetic. If anesthesia in a saphenous distribution is also desired, bring the needle back to the level of the subcutaneous space and redirect it medially. Inject approximately 5 milliliters in the subcutaneous space. This will block the saphenous nerve.
Posterior tibial nerve block. Anatomy. The posterior tibial nerve runs just behind the medial malleolus, and just posterior to the posterior tibial artery. Like the deep peroneal, the posterior tibial nerve is deep to the fascia. The posterior tibial nerve can be located just posterior to the medial malleolus, just superficial to the artery. Distribution of anesthesia. The posterior tibial nerve provides the majority of the sensation to the plantar aspect of the foot with minor contributions from the deep peroneal and sural nerve. The posterior tibial nerve also provides sensation to the heel of the foot. Technique. The surgical field should be prepared posterior to the medial malleolus. Identify the posterior tibial artery by palpating the artery posterior to the medial malleolus. Insert the needle just posterior to the artery until it penetrates the deep fascia. If the pop of the deep fascia cannot be felt, continue inserting the needle until it contacts bone. Withdraw the needle 2 to 5 mm and inject 3 to 5 ml of anesthesia. To increase the odds of a successful block, place an additional 3 to 5 ml lateral and medial to the original injection site. Pitfalls: intraneural injection will cause excruciating pain with injection, therefore withdraw the needle a few millimeters and continue injecting the anesthetic.
The following is a short clinical primer on the basics of performing an ultrasound-guided posterior tibial nerve block. This is meant as a summary for the practitioner already comfortable with ultrasound-guided procedures in general, and peripheral nerve blocks in particular. This presentation is not meant to take the place of supervised clinical training. Here we will review the indications and equipment required. We will then review the relevant anatomy and the specifics of obtaining reliable ultrasound images and successfully performing this nerve block. The indications for this procedure are straightforward. Plantar trauma, usually lacerations or puncture wounds. This is a difficult area of the body to anesthetize in a traditional sense. The equipment required for this block includes an ultrasound machine with a linear or vascular probe. You should select a local anesthetic, usually either lidocaine or bupivacaine, based on the duration of anesthesia required. Grab the syringe, needle, and something to clean the skin, and you're ready to go. Success with the tibial nerve block begins with a fine understanding of the anatomical relationships in the tarsal tunnel. Recall the medical school mnemonic Tom, Dick, and Very Nervous Harry that represent the various tendons and neurovascular structures of the tunnel, going from anterior to posterior. A good practical rule of thumb is to simply expect the posterior tibial nerve to lie posterior to the vessels. To begin the procedure then, recall the structural anatomy of the tarsal tunnel as you obtain your ultrasound views. The patient can be supine or prone. To take a linear probe in a transverse plane across the tarsal tunnel. The vessels are usually identified anterior to the nerve bundle. Fan with large strokes until you see a consistent hyperechoic signal representing the posterior tibial nerve. Once you have an adequate view, cut the skin in the usual fashion. Introduce the needle in in-plane fashion, taking care to avoid vasculature. Apply small aliquots of anesthetic to ensure your position. The target should be the epineuria and not the nerve itself. Look for hydrodissection as you introduce around 5 cc's of anesthetic, seen here. Test for effective anesthesia and repeat as necessary.
6. Superficial peroneal nerve block. Anatomy: the superficial peroneal nerve is superficial and runs along the anterior lateral portion of the ankle. It can be blocked by subcutaneous injection between the lateral malleolus and the tibialis anterior tendon. Distribution of anesthesia: this nerve provides sensation to the dorsal lateral aspect of the foot. Technique: identify the tibialis anterior tendon by having the patient dorsiflex the foot and inverts the ankle. The most prominent tendon should be the tibialis anterior. The surgical field should be prepared between the tibialis anterior tendon and the lateral malleolus at the level of the superior malleoli. Inject anesthesia in the subcutaneous space from the tibialis anterior tendon to the superior portion of the lateral malleolus. Pitfalls: intraneural injection will cause significant pain, therefore withdraw the needle a few millimeters and continue injecting the anesthetic.
The superficial peroneal nerve is superficial and runs along the anterolateral portion of the ankle. It can be blocked by subcutaneous injection between the superior portion of the lateral malleolus and the tibialis anterior tendon. The tibialis anterior tendon can be located by having the patient dorsiflex the foot and invert the ankle. It is the most prominent tendon. Here, the superior portion of the lateral malleolus is outlined in black. The tibialis anterior tendon is outlined in blue. The approximate injection point to block the superficial peroneal nerve is outlined in red. Inject from the tibialis anterior tendon all the way across the superior portion of the lateral malleolus.
7. Sural nerve. Anatomy: the sural nerve is quite superficial and can be blocked by anesthetizing the subcutaneous tissue from the superior portion of the lateral malleolus to the Achilles tendon. Distribution of anesthesia: the sural nerve provides sensation to the lateral aspect of the ankle and a small area on the plantar lateral aspect of the foot. Technique: the surgical field should be prepared between the Achilles tendon and the lateral malleolus at the level of the superior malleoli. Inject anesthesia in the subcutaneous space from the superior portion of the lateral malleolus to the Achilles tendon. Pitfalls: intraneural injection will cause significant pain, therefore withdraw the needle a few millimeters and continue injecting the anesthetic.
The sural nerve is quite superficial and can be blocked by anesthetizing from the superior portion of the lateral malleolus to the Achilles tendon. Here, the lateral malleolus is outlined in black. The Achilles tendon is outlined in blue. The approximate injection point lies along the red line. Inject anesthesia in the subcutaneous space from the lateral malleolus to the Achilles tendon.
8. Saphenous nerve. Anatomy: the saphenous nerve is a subcutaneous nerve that can be blocked by injecting anesthesia from the superior medial malleolus to the tibialis anterior tendon. Use caution around the saphenous vein. Distribution of anesthesia: this nerve provides sensation to the medial aspect of the ankle. Technique: identify the tibialis anterior tendon and the superior portion of the medial malleolus. The surgical field should be prepared between the tibialis anterior tendon and the medial malleolus at the level of the superior malleoli. Inject anesthesia in the subcutaneous space from the tibialis anterior tendon to the superior portion of the medial malleolus. Pitfalls: puncture of the saphenous vein. Intraneural injection will cause significant pain, therefore withdraw the needle a few millimeters and continue injecting the anesthetic.
The saphenous nerve is quite superficial and can be blocked by injecting anesthesia from the superior portion of the medial malleolus to the tibialis anterior tendon. The tibialis anterior tendon can be located by having the patient dorsiflex at the foot and invert the ankle. Here, the tibialis anterior tendon is located in blue and the medial malleolus in black. The approximate injection point runs along the red line. Inject from the tibialis anterior tendon to the superior portion of the medial malleolus in the subcutaneous space. This should block the saphenous nerve.